So when Celebrex first came out, it was kind of interesting because the class study only was talked about, and the results of the study were only available for the first 6 months. And so what we had was evidence of maybe not clinically important differences in ulcer formation between Celebrex and ibuprofen, but we had endoscopically observed reduction in the incidence of ulcers for Celebrex versus ibuprofen in the first 6 months. And so there was that level of evidence, which was pretty decent, that seemed to be proof that Celebrex was a safer agent on the gut than was ibuprofen and, by extension, other non-selective NSAIDs. However, some years after the class study and after Celebrex had been out on the market for half a dozen years, the FDA did an analysis of the class study and looked at the entire 1 year and beyond amount of time that was included in that study, and found that the second 6 months that there was no difference in endoscopically or otherwise observed ulcers between Celebrex and ibuprofen or other NSAIDs. And so in fact this gastroprotective effect that Celebrex seems to confer is only evident in about the first 6 months of therapy. If somebody is on chronic NSAID therapy beyond 6 months, then surprisingly enough there doesn't seem to be any difference between Celebrex and any other NSAID. There has never been any evidence that any of the NSAIDs is any more effective, and nobody can proclaim that any NSAID, including a COX-2, is more effective than another agent. But we have thought that perhaps the COX-2s were safer, and that may in fact be the case in the short term, but does not appear to be the case in the long term. Very briefly talk about the toxicity of acetaminophen. A couple things we know about acetaminophen is number one, it is not an anti-inflammatory agent because the reduction in the formation of prostaglandin PGE2 happens in the central nervous system only. It does not happen in the periphery, where that prostaglandin is able to cause edema and inflammation. So as we know, Tylenol is a good analgesic and good antipyretic agent, but is a very poor anti-inflammatory agent. And as you guys also no doubt know, Tylenol or acetaminophen has a dose-limiting toxicity. For a lot of years, it's been considered that the daily limit, should be about 4 grams per day. The FDA is now looking at changing that to 3 grams a day. I don't think that's actually happened yet, but the reason behind that is that about 4% of a dose of Tylenol is converted to a fairly toxic metabolite that is very effectively inactivated by the liver by this agent called glutathione. And so with doses less than 3 to 4 grams per day on a chronic basis, we don't have any problem because the toxic metabolites are completely cleared out of the body by glutathione. In doses larger than about 4,000 milligrams per day for some chronic use, then the liver eventually becomes overwhelmed. It can't produce enough glutathione to clear out that toxic metabolite, and so then you have very rapid actual death of hepatocytes, and you can get fulminant hepatic failure rather quickly, which makes overdose of Tylenol a rather problematic type of overdose. And this is actually a fairly good drug for people to attempt suicide with, because it's fairly quick in its ability to cause very profound hepatic failure. Just a couple comments on migraine drugs, and then we'll be finished up. Like the NSAIDs, there is no real good evidence that any particular triptan is more effective than another. The triptans are the agents that are far and away the most effective agents we have for aborting a migraine headache. They are never to be used as prophylaxis, and overuse of the triptan drugs are very much associated with causing rebound headaches and can actually get into a vicious cycle of causing the actual headaches. And so we get into a cycle where we're prescribing the triptans in order to treat the migraine headaches, but we're prescribing so many triptans that they're actually triggering the migraine headaches, and it's very difficult to get out of that vicious cycle. Since one of the main pathophysiologic findings in vascular and migraine headaches is cerebral vasodilation, the triptans work as serotonergic drugs, and we know from the discussion about SSRIs and platelets that serotonin is a vasoconstrictor, and so the triptan drugs are very potent vasoconstrictors and work by causing profound cerebral vasoconstriction. Of course, the problem with doing that is that patients that are at risk for stroke or hypertension or seizures can have very profound side effects from these drugs. We've seen arrhythmias caused, MIs, coronary artery spasms, strokes, hypertension, all in patients that have taken even normal doses of triptans. So using more than about 12 doses per month is relatively contraindicated and can cause quite a few profound problems. So in general, the rule of thumb is to keep doses of a triptan to less than about 12 doses per month to reduce the likelihood of these severe side effects and to reduce the likelihood of causing rebound headaches. Sumatriptan is the only agent that's available as a oral tablet and an injection and a nasal spray. These are the available triptans, and the only way that they really differ from one another is their onset of action, their duration of action, and their ability to prevent another headache from occurring within a couple-hour window. And so it's worth it in any given patient that doesn't have a good effect from one triptan to try another, but it's difficult to predict which agent is going to work for any given patient. Of course, since these are serotonergic drugs, we worry about combination with antidepressants or dextromethorphan or meperidine because of the risk of serotonin syndrome. Anybody with a history of angina or MI or uncontrolled high blood pressure is a very poor candidate for a triptan. Alright, I'm going to wrap it up. Look over these slides. One of the most important things we expect to see in patients that have migraine headaches is that they are treated with something to prophylax the headaches in the first place. If we see somebody that's on having headaches more than a couple of times per month, then they really should be on something to prevent their occurrence and on as low doses and low frequency as possible of the triptans. But we find beta blockers, calcium channel blockers, anti-epileptics, particularly topiramate, as being somewhat effective in reducing the incidence of migraine headaches. And sometimes you'll see amitriptyline or imipramine or the other tricyclic antidepressants used as well with some success. Most people have to try 2 or 3 different things before they find something that helps.